Good afternoon or good morning for those of you on the West Coast, and thanks for joining PQA today for our Quality Forum on the Quality Payment Program. Back in 2015, the Medicare and CHIP Reauthorization Act, or MACRA, was signed into law, which overhauled the way physicians are paid by putting a higher priority on quality of care delivery. After the first year of implementation, has this legislation created the impact that was anticipated? My name is Hannah Fish, and I serve as PQA's Associate Director of Education and Communications. It's my pleasure to moderate today's presentation, where we'll hopefully answer that question. Before I begin, I would like to call your attention to two housekeeping items. One, attendee lines have been muted. You are encouraged to submit your questions throughout the presentation using the questions panel located on your control panel, which is usually on the right-hand side of your screen. At the conclusion of our speaker's presentation, I will read the questions for him to answer. Secondly, this quality forum is being recorded. The recording will be posted on the PQA website next week. It's now my pleasure to introduce our wonderful speaker for today, Mr. Jim Scott. Jim is President and CEO of Applied Policy. He founded the company to apply his in-depth and insider knowledge of the federal health policy to help healthcare providers and companies succeed. As a member of the Washington, D.C. health policy community for over a dozen years, he has gained valuable experience and contacts in both the government and private industry. Mr. Scott was with the Office of the Legislative Counsel of the United States Senate, where he was a principal drafter of the Medicare Prescription Drug Improvement and Modernization Act of 2003 and other Medicare legislation. He also served at CMS, where he advised the CMS administrator on congressional intent in implementing the Medicare Modernization Act of 2003 and engaging members of Congress in implementation of the new Medicare prescription drug benefit. It's now my pleasure to turn it over to Jim Scott.
Thank you, Hannah. Today I'm going to talk about Medicare's Quality Payment Program, which I believe is here to stay. There are about 1.5 million clinicians billing Medicare Part B, and CMS projects those clinicians will bill $124 billion in 2018. But for now, more than 60% of those clinicians are excluded from the Quality Payments Program, and the bonuses and penalties will be smaller than those participants expect. Nevertheless, over time, bonuses, penalties, participation, and performance requirements will increase. So it's good that you're here at the beginning to get a good handle on the basic program elements right from the start. So today is just an overview. On November 16, 2017, the Centers for Medicare and Medicaid Services, or CMS, released a 662-page final rule with comment period going over all the details of the Quality Payments Program. Then, on February 9th, 2018, the President signed the Bipartisan Budget Act, and that changed the program in important ways. So we'll talk about both those things. We'll spend most of the time on what people call MIPS, the Merit-Based Incentive Payment System, since that's how most clinicians will participate in the program. But then I'll also touch on advanced alternative payment models, since about 5% of clinicians will participate in the program that way. And then we'll wrap it up with some key takeaways. So let's start with an overview. One of the hallmarks of applied policy is to translate complex rules and regulations so our clients understand the programs in a way that empowers them to make smart decisions. And that's what I'm hoping to do with you here today. First, there's some important terminology. I've heard a lot of people using MACRA, MIPS, QPP, and other acronyms interchangeably, often in quick succession, to really sort of confuse things rather than clarify. So right up front, I want to demystify these for you. The Medicare Access and CHIP Reauthorization Act of 2015 is called MACRA. it created what CMS calls the Quality Payment Program, the QPP. Starting in 2019, physician payment will still be made based on a fee schedule, but CMS will adjust the fee schedule payments based on their performance under the QPP. Clinicians who participate in the QPP have two options of how they can participate in that program. One way is through the Merit-Based Incentive Payment System, or MIPS, and that can also include participation in some alternative payment models. Or instead, they can elect to participate in advanced alternative payment models, such as accountable care organizations. CMS estimates, and we agree, that the majority of physicians will elect to participate in MIPS rather than APMs. Another important concept before we move on is that performance year and payment year are two different years. So for 2017, which is a performance year, so 2017 measured performance, but the bonuses and penalties will apply to payments for services delivered by that physician in 2019. So MACRA created the Quality Payment Program, and you can see here illustrated that the Medicare physician fee schedule is the current payment methodology, and the fee schedule still stays there. However, it gets adjusted based on whether or not the physician or clinician chooses to participate in the merit-based incentive payment system. Then the MIPS, you can get the MIPS adjustment, or you can also participate in an alternative payment model using modified MIPS scoring. So the program is really driving physicians and clinicians who are required to participate into considering at least participating somewhat in alternative payment models. There's a special kind of alternative payment model called an advanced alternative payment model, and we'll talk about those near the end of the presentation. But for now, just know that CMS makes a list of those, and physicians who participate in advanced alternative payment models don't need to participate in MIPS. So even though the Quality Payments Program itself is new, it actually replaces several existing CMS quality reporting programs. If you've heard of the Physician Quality Reporting System, or PQRS, the Electronic Health Records Incentive Payment Program, or the Value-Based Modifier Program, they're all combined and replaced by the QPP. So if you are familiar with those programs, a lot of the concepts stay the same, and a lot of the quality metrics are ones that you're probably familiar with. Also, it's important to note that more than 1/3 of Medicare beneficiaries get their health insurance through Medicare managed care, and that's called Medicare Advantage. So for Medicare Advantage, the enrollees and the payments are not affected by the MIPS or the QPP. So the participants are excluded, and the amounts billed to Medicare Advantage don't count. So let's now take a deep dive into the merit-based incentive payment system, because that's how most clinicians who participate in the QPP will end up participating. So first of all, who needs to participate? Well, you might have noticed I've been trying to refer to participants in MIPS as clinicians, because it includes more than just physicians. You can see on the left-hand side of the slide who participates in 2018. The Medicare statute considers optometrists, chiropractors, podiatrists, dentists, and dental surgeons as physicians for the purpose of furnishing the services they're authorized to under their state scope of practice laws and that are covered by Medicare. Also included are physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. On the right-hand side of the slide, you can see who does not participate in 2018. Clinical psychologists, licensed clinical social workers, and others. But the statute specifically specifies that after 2018, CMS has the authority to add these professionals as participants. In its final rule, CMS says that for the clinicians who aren't selected for participation currently, they will consider expanding the participant list based on how they would be scored for each performance category. One question you might have are, where are the pharmacists? So the statute doesn't give CMS the authority to add pharmacists to the quality payments program. Instead, CMS encourages their participation as part of care teams, and particularly with respect to medication reconciliation measurement. So for MIPS, payments are adjusted based on a composite score across 4 categories. The score totals to 100 points, and you have to score more than 15 points to avoid a penalty, and more than 70 points to earn a bonus. So you can see from that scoring methodology, it's really easy to avoid a penalty and really hard to earn a bonus. And we'll come back to that later and the implications of that. So the 4 categories are quality, resource use, that I usually refer to as cost, clinical practice improvement activities, and advancing care information, and that's what happened to the EHR program. So for quality, participants have to report on at least 6 quality measures, including 1 outcome measure or 1 high priority measure. CMS provides a list of more than 200 measures clinicians can select from. They can report at the individual level or at the practice level. And CMS has also provided measure sets tailored to specific medical specialties. For the cost category, participants are evaluated based on total spending, including total cost per capita for Medicare beneficiaries and Medicare spending per beneficiary. The Bipartisan Budget Act of 2018 made some changes to the cost category, but nothing that affects what's here on this slide. The clinical practice improvement activities include activities both at the patient and the population level designed to improve overall health outcomes, and then advancing care information is the use of electronic health records. And CMS gives a additional bonus for using a 2015 certified version, but you can use a 2014 or a 2015 certified version to earn those points. For the composite score, you can see on this slide that for 2019 payment, quality is 60%, the clinical performance improvement activities, the CPIA, and the electronic health records are 15% and 25% respectively. For 2020 is when they start adding the cost category at 10%. This is where it's important that the 2019 payment year is actually based on the clinician's performance in 2017. So their performance has already happened, but the payments won't happen until next year. So if you're looking to see what's going on in 2018, that's the graph that shows 2020 payment, where cost is 10% of the total score and quality is 50%. One of the things that the Bipartisan Budget Act changed that we'll get to in just a minute is important to note here. It changed the transition period from 2 years, which were payment years 2019 and 2020, to 5 years, from 2019 to 2024. So but the legislation wasn't very specific on the details of how CMS should extend that phase-in period. So we'll be looking for CMS to issue a rule this summer that proposes the details. So while what's on slide 10 is what's current for now and in CMS's final rule, there are some things about this that might change in the near future. On the next slide, you can see that for 2019, the payment incentives are modest. For a physician with $1 million in fee schedule billings, they could earn a bonus or penalty of about $40,000, which is paid out one claim at a time over the whole year of 2019. But you can also see that over time, the payment incentives increase to a maximum of 9% in 2022, which would be performance year 2020. As I mentioned at the beginning, CMS estimates that 60%, actually more than 60% of clinicians currently billing Part B will be exempt from MIPS in 2018. So out of the 1.5 million Medicare billers I mentioned at the beginning, you can see from this slide that almost 1 million are excluded. The statute says that clinicians excluded due to the low volume exception are not eligible. Therefore, they're not allowed to participate even as an option. CMS also has broad authority regarding the low volume exclusion. In 2017, the low volume exclusion affected physicians and other clinicians that with less than $30,000 in Medicare Part B billings or less than 100 Medicare Part B patients. You can see that for 2018, CMS significantly increased the low volume exclusions. So it's $90,000 in Medicare Part B payments or 200 Medicare, less than 200 Medicare Part B patients. The Medicare charges that aren't billed under the Medicare physician fee schedule, such as physician administered drug costs, don't count towards the physician's payment calculation. This is one of the changes that was made by the Bipartisan Budget Act. Also, before enactment of the Bipartisan Budget Act, CMS estimated that 540,000 clinicians would be exempt, but because the number of services is smaller that count after the enactment of the Bipartisan Budget Act, we expect that CMS estimates regarding the number of excluded clinicians are low, and those will increase when CMS reestimates it based on the implementation of the Bipartisan Budget Act. So I've mentioned it a few times. So let's go over what were the changes in the Bipartisan Budget Act that was just passed this past February 9th. So I have a high-level summary on slide 15 of what I think are the 4 key changes made by the Bipartisan Budget Act to the Quality Payments Program. So before the Bipartisan Budget Act, all Medicare Part B items and services, including physician-administered drugs, were included for purposes of MIPS. After the Bipartisan Budget Act, only Medicare physician fee schedule services are included. There was a 2-year phase-in under the MACRA version. After the Bipartisan Budget Act, it's extended to a 5-year phase-in. Before the Bipartisan Budget Act, CMS had broad discretion regarding the implementation of the cost category. After the Bipartisan Budget Act, Congress gave CMS more instructions regarding the implementation of the cost category, which I view as a limitation. And there's also the PTAC, which is a committee of physicians that are help design advanced alternative payment models. Prior to the Bipartisan Budget Act, there was some feeling that PTAC was not allowed to provide stakeholder feedback on submitted proposals before reaching a decision about them. And so the Bipartisan Budget Act clarified that the PTAC is allowed to provide stakeholder feedback prior to making a final decision regarding proposals. So let's look at each of those in a little more detail. The Bipartisan Budget Act changes the focus of the program from all items or services covered under Medicare Part B to only those reimbursed under the Medicare Physician Fee Schedule. For purposes of determining the low volume exclusions beginning in 2018, both for purposes of counting numbers of patients and for purposes of counting dollars, only services paid under the Medicare Physician Fee Schedule count. The MIPS adjustment factor, this is how CMS awards the bonus. So it's that up to 4% I mentioned on the prior slide. It only applies to payments under the Medicare Physician Fee Schedule. And it appears that the legislation made this effective for payments beginning in 2019. One of the things I'll be watching for in CMS's implementation is, will CMS also interpret it that way? Because it seems a little bit unfair to apply a new bonus methodology after the physicians and other clinicians have already completed the performance year that forms the basis of earning those bonuses. The other issue is that some physicians administer physician-administered drugs, which could account for a large portion of their overall Medicare Part B billings, that originally would have been included as part of the payments that would have received a bonus payment on top of that. However, the Bipartisan Budget Act exempted drugs and anything else that are not reimbursed under the Medicare Physician Fee Schedule. It also extends the transition period from 2 years to 5 years. It directs CMS to increase the performance threshold over the 5-year transition to ensure a gradual and incremental transition in the 6th year. And so that's the language that I referred to previously that didn't provide a lot of detail about how to extend the transition, just to let CMS do it gradually and incrementally. So we'll see in their proposed rule this summer, how does CMS interpret that, and are they changing anything about their currently planned schedule for implementation? The Bipartisan Budget Act also limits the application of the cost category. It says during the 5-year transition, CMS cannot consider improvement in resource use as part of a clinician's performance score. It also limits the cost category to not less than 10% and not more than 30% over the first 5 years of the program. This would permit, but not require CMS to maintain the cost category weight at 10% next year instead of moving it to 30%. A lot of commenters have asked for that, but we'll see if CMS uses its new authority to take action on that. The way the law is drafted, they could keep it at 30% next year if they wanted. Also, the section allows the Physician-Focused Payment Model Technical Advisory Committee, that's the PTAC, to provide initial feedback to stakeholders regarding alternative payment models submitted for consideration. So the next thing I'd like to talk about are advanced alternative payment models. So as you'll recall, this is the other way clinicians can participate in the quality payments program and it will exempt them from having to participate in MIPS. So you do one or the other. It's either MIPS or an advanced alternative payment model. So clinicians have two different options for participating in the quality payments program. This is the second. Clinicians who participate in the MIPS program have to meet the MIPS requirements that we already outlined and are eligible for the MIPS payment adjustment, that's the plus or minus 4%, on an annual basis. Clinicians who choose to participate in some alternative payment models, those not deemed advanced by CMS, are eligible for the MIPS adjustment. However, they get assessed using a modified scoring system that incentivizes them to have some exposure to alternative payment models. These providers are only required to meet the quality, cost, and EHR requirements specific to their alternative payment model in order to qualify for the MIPS adjustment. Clinicians who participate in advanced alternative payment models, or AAPMs, are eligible for additional lump sum bonus payments. AAPMs generally require providers to take on financial risk in order to participate. And that's why they mentioned that the cost category isn't considered, because the advanced alternative payment model itself is encouraging cost efficiency. In exchange for taking on this additional risk, providers are eligible for a lump sum bonus of 5% of their Part B payments. Advanced alternative payment models require participants to take on financial risk. So in order to earn the bonus, providers must receive 25% of their Medicare in order to earn the bonus, providers must receive 25% of their Medicare Part B payments through a designated AAPM, or must see 20% of their Medicare patients through an AAPM. CMS is maintaining a list of advanced alternative payment models. In 2017, the agency designated these programs listed as advanced alternative payment models. The Center for Medicare and Medicaid Innovation, as part of its request for information, also took a lot of suggestions about what kinds of additional advanced alternative payment models should they consider. But for now, only about 70,000 clinicians are expected to participate in advanced alternative payment models, and those are primarily, those physicians know who they are because they're generally participating in a CMS-approved pilot program like the Next Generation Accountable Care Organizations. So let me give you some key takeaways. I think that this program really makes quality an important part of Medicare, and this program is here to stay. The bonuses, penalties, and participation and performance requirements are going to increase over time. And we've seen this before. For example, if you're familiar with the Medicare Advantage Star Ratings programs, CMS took a lot of criticism near the beginning of that program for making it too easy to award the bonus payments. So I think, but overall, the Medicare Advantage Stars program is here to stay, and making it easy at the beginning, I think, encouraged a lot of participation and got the buy-in while CMS got the program up and running. And I think we're seeing some of the same things here. So don't be worried that the Quality Payments program is going away. It's not. The bonuses and penalties will increase over time, and one of the important things that needs to happen is the measurement of quality. And one of the things that you'll see in the President's budget proposal this year is that there's a drive to make those measures easier to report, so there's less of a documentation burden on the participants in the program. The role that PQA can play here is make sure that the measures are meaningful and measure things that are important to Medicare and also to the patients and also to the providers. But for now, more than half of the clinicians in the U.S. are excluded from participation and can't participate even if they want to. And it's actually more than that, more than 60%. Of those who do participate, most will participate in MIPS, and that's why I spent most of the time on that. But the bonuses and penalties will be smaller than the participants expected, for the reasons I said. You know, if you score between 15 and 70 points, you get no bonus and no penalty. And then you really need to score more than 70 points out of 100 to get the bonus. And it seems hard to me to score less than 15 points and have participated at all. And those are the only ones who are going to get the penalties. So overall, I think the bonuses and penalties will be smaller than participants expect. Now we have time for questions.
Absolutely. Thanks so much for the presentation, Jim. And I would encourage all attendees on the line to submit your questions. Again, as a reminder, the question and answer function is in the question panel on typically the right-hand side of your screen, unless you've moved it. But we'll start off with the first question that we received, Jim, and that is, what should the pharmacy profession be doing in terms of educating or helping to educate the leadership in CMS to encourage them to be considered as an eligible clinician in the quality payment program? I know you said statutorily it's a challenge right now, but what else besides just participating on the care team do you think the pharmacy profession can do?
That's exactly right. So the pharmacist commented on the rule and said just what Hannah said, and CMS responded that it was beyond their authority to include pharmacists. So it's actually not CMS that needs the education, it's Capitol Hill and the president who can make the difference by adding pharmacists as an eligible participant. The list of eligible participants that's in there now is comprised of professions that can already bill Medicare in some capacity. So another step towards getting pharmacists recognized under the quality payments program and able to earn a bonus and a penalty or receive a penalty for poor performance would be to have Medicare recognize pharmacists as service providers under the Medicare program and eligible to bill Medicare for other purposes. The other important thing to keep in mind is that based on the Bipartisan Budget Act, the way that the changes were made, only the services reimbursed under the Medicare physician fee schedule would receive the bonus payment or would be subject to the penalty. So it would be important, you know, as the pharmacists work to gain recognition to bill Medicare directly for broader purposes, that you also consider exactly what services are they going to be reimbursed for, and would participation in the quality payments program and a 4% bonus on top of those billings be an incentive for pharmacists?
Excellent. Thanks. I think that's very insightful for understanding some of the ways that pharmacists can help and maybe some actions to take at a legislative level as well. So in terms of the measures that you talked about, and stating that quality is here to stay, you frequently hear that there's lots of measures in the marketplace, and with the Bipartisan Budget Act trying to make it easier to report and less burdensome to document. But there's so many measures out there. How do you propose, or what are your thoughts on harmonizing measures and really trying to use these other eligible professionals to help physicians meet these metrics to really capitalize on the bonus payments that are available?
Well, I think, CMS does encourage care teams, and the advanced alternative payment models, of course, are much more flexible than the MIPS program. So those are, sort of obvious avenues, but the vast majority of the whole program is set up so that it's unclear how it's going to drive meaningful improvements in quality. And by that, I think, in my opinion, that the bonuses and penalties are too small to really drive meaningful change. And there's too many quality measures, and it's too open as to which quality measures clinicians pick. So the incentive is always for clinicians to pick quality measures where they're very confident they're going to score high, rather than pick quality measures where they could use improvement. And I'm hopeful that over time, the program is going to evolve so that it encourages physicians and other clinicians to take on challenges to pick quality measures where they could show a meaningful improvement, not just the quality measures where they're confident they can, hit a home run.
Excellent. So staying on the topic of measures, we have a question that came in that asked to provide some examples around the activities and types under the clinical improvement activities aspect of the MIPS program, and whether or how pharmacists are able to assist in that particular area of MIPS.
Right. The clinical improvement activities are really focused on population health. So, of course, pharmacists often have contact with patients and can be part of care teams, and often have collaborative agreements with physicians. So in that role, I think pharmacists can really contribute to the population health improvements and provide important insights to their clinician partners who are subject to the bonuses and penalties under MIPS.
Excellent. And this must be another topic on the minds of many of our viewers today on the Quality Forum, because I'm seeing several questions come in around MedPAC. What are your thoughts on the role MedPAC will play in MIPS? And you've said it here that the quality payment program is here to stay, but there's rumors that this might all disappear. So what are your thoughts on MedPAC and MIPS going away?
Well, the important thing to note about MedPAC is they're not a policy-making group. They make recommendations to Congress, and their recommendations regarding the quality payments program were available to Congress at the time that the Bipartisan Budget Act was enacted. So to me, the Bipartisan Budget Act was the opportunity for the Congress to really take, MedPAC's recommendations to heart. Over time, I think that, paying for outcomes and really looking at quality improvement rather than paying for the volume of services delivered is the direction of the whole system. And one of the things I get a little bit frustrated with personally is that, in 2015, Congress passed MACRA. We don't get to the first payment year until 2019. And before the program ever had a chance to work as initially envisioned, Congress had changed it. So for those of you out there that are scientists, it's almost like running an experiment, and you change so much halfway through it that you never know, did you achieve your intended, effect or not. So I think Congress would be best to let the program run and leave it to the agency to make improvements, and then for external partners like the Pharmacy Quality Alliance and others in the quality system to work to develop the meaningful quality measures that are relatively easy to report, that don't add to clinician burden, but really measure what high quality healthcare should be. And I think that's an evolving process. But I don't think that it's likely that we go back to the sustainable growth rate system before, or just let the system run without any emphasis on quality at all, like the old Medicare physician fee schedule did.
Excellent. Thank you. And I encourage our viewers on the line to continue submitting questions. We've gotten some really great questions submitted so far, but continue to send those in to us. So the next questions kind of go hand in hand and have come through still on this kind of topic of measurement and what you alluded to in this kind of choose your own measure pathway that we've heard about. But as part of that choose your own pathway, can you clarify whether that's in the statute or whether that's in the rules from CMS, and how easy that might be to change the number of measures that the physicians are required to report on and to pick? And then going hand in hand, how do you know what the physicians are picking and what they're choosing to report on? And is that available for pharmacists, per se, to know and understand so that they can help and collaborate with the physicians to help them meet those metrics?
So there's a few questions in there. So the choose your own path is made through regulation, and that's what takes up a large amount of the more than 600 pages of final rule, is going through each subspecialty's measure set and listing off the measures and considering the comments relating to that. One of the frustrations of a lot of clinicians out there is even with that level of detail, there are still many subspecialties that can't find meaningful measures to report on. So that's within the discretion of CMS to refine and revise. The weighting of those measures is somewhat flexible, but with some direction of Congress. But right now, it seems like there are, sort of too broad a range of measures, and it's to some extent questionable as to whether those measures are really measuring high quality healthcare or whether those measures are really, designed to be simple so that physicians and other clinicians participating in the program can get comfortable with the system before the performance expectations get ratcheted up.
Excellent, good to know, and thanks for clarifying that point. So another question that we received is around the eligible clinicians, and with some of the changes, having some of the eligible clinicians then drop out. So are there any medical groups that are organizing to try to now get these physicians back in and back eligible to participate in the programs in the APM?
So with respect to MIPS, the list of eligible clinicians that I showed on the slide, the ones participating in 2018 are specified in the statute. The ones that aren't participating that I listed on the right-hand side of that slide are the ones that the statute allows to participate, but CMS has to basically add them, one or more at a time. And as of the final rule that was published just, last November, CMS didn't say anything about adding any new clinicians. I think one of the key things is in considering the clinicians, like registered dietitians, the clinical psychologists, the licensed clinical social workers, and the others, is to figure out how would they participate in the system and how would their performance be measured, and would that be fair? So I expect that all those groups are considering what the best way to do that is. I don't know whether they want to be in or out. Again, a lot of those groups, see some Medicare beneficiaries, but the way the system is set up to, provide a 4%, bonus payment on, the CPT codes that are submitted under the Medicare physician fee schedule, the bonus, could be modest, really modest, developed based on their practice mix and how many Medicare beneficiaries they see.
Excellent. So I think we've got one more question that has come in, unless anyone would like to send in their additional questions. And that is on the quality registries. You haven't really touched on those yet today in your presentation. But it seems like they're proliferating as greatly as the docs use the registries for reporting purposes. So do you think there's enough standards around those registries as an option for the quality reporting and the quality measures that physicians can pick from and use?
So what Hannah's alluding to is the qualified clinical data registries, and those do provide a means of reporting the quality measures. A lot of specialty societies operate registries often for their own purposes. You can arrange those so that they capture the information related to the CMS selected measures, and then by participating in the registry, the clinician can meet their reporting requirements for a whole measure set. Right now, the Qualified Clinical Data Registries, or QCDRs, are certified based on self-attestation. So there is a big risk for a qualified clinical data registry run by a specialty society to self-attest if they don't actually meet the requirements. I don't think we've seen really any major problems yet with those that have self-attested, but the questioner is correct. There aren't a lot of requirements around those, and we'll have to see as those proliferate. Does CMS need to tighten up the regulations about who can be a qualified clinical data registry? But for now, it's really an excellent avenue to reduce clinician burden and to reliably capture the quality data in a standardized way that it can then be used to track performance improvement.
Excellent. Thanks for those insights. So as a moderator prerogative, I have one final question, and throughout the presentation, you've given us some great insights and let us know what has changed and what some of the implications are. But if you were to look at this new bipartisan budget act that was just passed, what's the biggest or the key takeaway just from what's passed that everyone in the measurement space and the healthcare space should really pay attention to and take away? What's that one thing? Or a couple of things.
So what I was a little bit surprised at is, I guess maybe I'm just more aggressive by nature, but it does seem like the Bipartisan Budget Act excludes more clinicians from participation, and also really reduces the opportunity for bonuses by limiting the bonuses to the services billed under the Medicare physician fee schedule, which is a lot fewer services than was imagined by when it was originally implemented in MACRA. So if it were up to me, I would be, a lot more aggressive, have a lot, more substantial bonuses, and exclude many fewer clinicians, and focus on the ramp up to really try to drive quality improvements for Medicare beneficiaries.
Excellent. Well, Jim, thank you so much today for sharing your insights and providing these updates and making sure that we're all aware of what to be on the lookout for here coming in the next couple of months, and especially hearing CMS's rules come as a result of this new act. So I just want to conclude today's webinar with some final announcements. The first being next month's Quality Forum is on March 9th, so please save the date for that. We will be having Dr. Maureen Mavrenak, who wrote A Narrative Matter, an article rethinking the traditional doctor's visit, which was featured in the February issue of Health Affairs, and she'll discuss a creative model for primary care delivery, the shared medical appointment. Also, don't forget, our PQA annual meeting is coming up here soon in the next couple of months. Please register for the May 16th through 18th meeting in Baltimore, Maryland. Please check your emails or our website for the information on how to register. Also, at the conclusion of this webinar, a survey will pop up. We would love your feedback on our quality forums. We're always looking for new ideas and new speakers that we can have join us. So we appreciate you taking 2 minutes to fill out that survey. So I just want to take one last minute to thank Jim, our speaker, for joining us today, and thank you all for attending. We look forward to having you join us on the future Quality Forum webinars. Have a great afternoon.